Good morning, or afternoon, or night, or whenever you may be watching this virtual presentation entitled The Imaging Physician's Role in CT Protocol Design and Review. My name is Christopher Hess. I'm one of the faculty in the Neuroradiology section at the University of California, San Francisco. And just in case you've gotten lost within the virtual symposium, you are still participating in the Radiation Safety and Computed Tomography Symposium. I have no disclosures relevant to this talk, and in this talk what I hope to do is simple two goals. Number one, we'll be discussing dose reduction steps that were taken in the neuroradiology section at the University of California, San Francisco. Our busy colleagues in neurology, neurosurgery, ENT, and other fields really provide a large volume of studies of the brain, spine, head, and neck that we've used to adapt our practice in view of new radiation concerns that have developed over several years. I should mention outright that because I'm a neuroradiologist, the examples I will be discussing come from my field, but the concepts are applicable to computed tomography in any area of the body. What I'd like to do is to develop an approach. This is like interpretation of a chest x-ray, if you will. By analogy, it really doesn't matter how you do it, but you have to go through each part of the approach. You have to develop your own approach and look at the different areas of the lung, find the trachea, see if it's deviated, find the heart, see if it's too big. Well, in a similar fashion, when you're evaluating neuroradiology or other body section protocols, you have to develop an approach and one that works for you. And I will be discussing my approach. Specifically, we'll also address how these were implemented in our practice at UCSF. And the real message that I hope you take home from this virtual presentation is that you, as the imaging physician or the technologist, have the most significant influence on patient radiation dose, much more than you probably imagine. Of course, your scanner vendors and your physicists play an important role, but it's you who are in the direct zone of contact with the patient, and it's you who are defining how imaging is used to determine the diagnosis. It's really incumbent on you as the imager to be familiar with the impact of dose on the individual patient. Throughout the virtual symposium, I'm sure you will see many stories along these lines, but lack of familiarity with radiation issues on a clinical level can lead to some big mistakes. Some of these are very highly publicized, like this one from the New York Times, in which a CT was done incorrectly by a technologist in Northern California, and instead of a usual 1 to 2 minute scan, a 1 hour scan led to a linear burn on the patient and many years of worry about the latent risk of carcinogenesis. These are the stories that you want to avoid, certainly in your practice, and some simple steps can be used to avoid those. What I'm going to discuss is 5 general steps that I believe can be used to approach dose reduction from the standpoint of protocol design and review. First of all, we'll be discussing how to review clinical indications for studies. This is, of course, part of your training as a radiologist. It's impossible to describe this within a few-minute presentation, but we'll review some general guidelines. Second of all, discussion with referring providers can really make a big difference in your practice in designing your protocols. Next, we'll move on to the idea of developing CT protocols that are matched to a particular indication, something that's not always performed but is certainly at the disposal of the radiologist who is engaged in reducing radiation dose in their practice. Next, I'd like to emphasize how important it is to standardize your protocols so that they're used consistently across the institution. And finally, I'll emphasize the importance of performing periodic case review for quality assurance purposes. So let's start with the concept of appropriate utilization. This is part, as I mentioned, of the usual training of imaging physicians. It's certainly difficult to summarize, but some of the most important considerations include the seriousness of the diagnosis being considered, the pretest probability, whether the diagnosis is likely or unlikely, the consideration of available data. Did the patient have the same examination yesterday, for example? how the imaging will impact the management of the patient, and the availability of any alternative tests with similar accuracy. Examples that are well cited and that you're well familiar with in your practice include ultrasound for appendicitis in children. In our practice, we now use MRI routinely in children with suspected hydrocephalus who have a known ventriculoperitoneal shunt due to the cumulative dose effects of CT. In most busy practices, it's simply not enough time to perform a review of the patient's medical record and to consider all of the potential options. Recent publicity has certainly made your referring providers, your ER radiologists, your ER physicians, your referring colleagues in different practices, keenly aware of the issues in CT, but it hasn't changed their obligation to appropriately evaluate patients. But their awareness of the issue makes them much more receptive to discussions of appropriateness. So setting aside some time with physicians to discuss workflow options and strategies for specific clinical indications can go a long way to enhance the care that patients are given and can enhance your business practice as well. As an example from our practice, by partnering with our ER physicians and our child neurologists and our stroke neurologists, we agreed that patients below a certain age suspected of having an acute stroke would be imaged with MRI instead of a high-dose stroke protocol CT angiogram, which, as you know, has a much higher patient dose. This was adapted to certain scenarios in which the patient may not be eligible for TPA and was adjusted on a patient-by-patient basis in cooperation with our referring physicians. As another example, which I previously mentioned, one of the patient populations at highest risk due to cumulative doses in head CT is children with ventriculoperitoneal shunt catheters. To avoid repeated CT, these patients are triaged to very fast MRI protocol that really is sufficient to evaluate ventricular size, and I'll mention that later in the discussion. My experience in talking to most radiology practices around the country and even around the world has been that there are a limited number of CT protocols used in any individual practice. There's very little coordination across practices, across colleagues, across institutions, and even within the same institution, there's very little effort to coordinate obtaining the same scan, the same quality scan, and the same parameters on the same scanner within an individual institution. There may be two brain protocols, one with and one without. There may be a single acute stroke protocol or one neck with contrast. And in other practices, such as our own, we found that dose reduction can be achieved by tailoring the protocol to match the indication. So some examples of tailored protocols in our practice are those for low-dose head CT, in which visualization of the brain parenchyma may not be necessary. Patients who have suspected craniosynostosis based on physical examination, in our neuroradiology practice, for example, it is only necessary to visualize the bone, and therefore low dose can be used. When a patient has a known aneurysm and serial examination is performed to evaluate whether the aneurysm is growing or not, CT angiography is sometimes performed. If there's only one protocol, this may require the acquisition of a non-contrast scan in addition to the CT angiography. In our practice, when we know a patient has an aneurysm and is not suspecting having acute hemorrhage, we will obtain only the CTA and narrow the field of view to the region of the known aneurysm. Spine protocols in our practice have been adjusted to those patients with and without hardware, and based on body part, the dose is much lower in patients with cervical spine imaging and considerably higher in those patients with lumbar spine imaging, especially if they have hardware. The dose is adjusted based on the indication. We routinely perform low-dose scans in a number of scenarios, including screening of the orbits for metallic foreign bodies prior to MRI. We use very low-dose scans for studying facial bones, bony structure, paranasal sinus examinations, and orbits. Higher dose examinations, or the potential for higher dose, like single level acquisitions, such as with perfusion imaging, are often done in practices, especially with patients with stroke. In our case, we have avoided doing those examinations unless they are absolutely indicated. For CT-guided interventions, which we use in our practice for treatment of spinal pain and for biopsies and a number of other procedures, we will specifically use a low-dose approach that I will mention in just a few minutes here. So one example, spine protocols for hardware. In the case of hardware, it may be necessary to increase dose rather than reduce dose in order to visualize the neural foramina and spinal canal in patients with suspected myelopathy or radiculopathy in the presence of hardware. In order to do that, to increase the dose, the tube voltage, the tube current are increased, the pitch is lowered. You can see different steps on this slide that are taken to increase the dose in a strategic fashion to better visualize around the metallic hardware. So let's take the example of a 63-year-old man who has a prior history of anterior cervical discectomy and fusion. He also has posterior fusion at the levels that I will show you. He has an acute onset of neck pain and left hand tingling, and the treating surgeon is suspicious for an acute disc herniation. On the top images you can see how using a standard tube voltage and a programmed protocol, or a default protocol, results in significant beam hardening artifact around the spinal canal. There's larger areas and lower frequency areas of beam hardening artifact that narrow through the canal, and in particular the left aspect of the canal. By adjusting the dose parameters, by increasing the tube voltage, increasing the pitch in this case, and decreasing the slice thickness, notice how we can visualize the left aspect of the spinal canal better. Overall, if you take a step back and look at this image, the fluctuations around the hardware due to the beam hardening artifact are reduced. In particular, the higher frequency fluctuations, the smaller lines emanating from those structures, are no longer present. Or how about in this scenario? This is very frequent, I'm sure in your practice as it is in ours. A 3-year-old with a remote history of meningitis who may develop ear infections or a viral infection periodically, come admitted with a headache, had a remote history of meningitis, or your ER physicians are concerned that they have perhaps new encephalitis or meningitis, or they're developing hydrocephalus. This is a patient who returned very frequently to our emergency room, and in fact, when we looked at the record 2 months previously, you can see the CT that had been unchanged from several prior CTs with the same concern. Once we made the switch to a rapid MRI, this is a very short examination, 5 minutes or less, consisting of single-shot vascular echo, axial, coronal planes, also diffusion as well to look for infection or other causes of altered mental status or acute abnormalities. A very fast protocol, thereby completely obviating the need for radiation. A third example is our practice with CT-guided interventions. Traditionally, this was done with repeat CT at the same level during the guidance of a needle. In this slide, I'm showing you 4 different phases that we consider of the examination. Moving from the left to the right, the survey phase is essentially the operative planning phase. The fiducial phase involves placing a BB on the skin to determine where the needle should enter the skin and find the nerve root. In the guide phase, there are several serial images in which the needle is advanced to the nerve root. And finally, in the contrast phase, the nerve root is injected with contrast. Contrast envelops the nerve root and passes around it, and this is a way of verifying where your medication is being distributed. And the top row consists of cases that were done using a standard higher dose protocol in 2009, and then in 2010 where we used our lower dose protocol. How did we do it? In the survey phase, we targeted specific levels. We reduced the z-axis scan. In our fiducial and guide phases, we used very low tube current, actually on the order of 10 or 20 MA. And in our contrast phase, we increased the MA only slightly, back to around 30 or 40 on average. And as this plot shows you, there's a significant dose reduction that occurred over those 2 years in a study of many cases that we did. The largest reduction was in the survey phase by using a targeted z-axis approach, but overall we achieved up to an 8 to 10 times reduction in dose. Something similar could be done in just about any CT-guided procedure if done correctly. Finally, once your CT protocols are developed and matched to indication, it's absolutely essential that these be standardized so that they're as similar as possible across your own institution. The actual protocols should be stored in hard copy for your review, and they should be reviewed periodically by you and your colleagues to ensure that they are being used consistently across the institution. How does a CT protocol look? This is an example of one protocol in our institution. This particular protocol is a 3-phase examination. The technique parameters are listed in various forms across the diagram. The reconstruction techniques are also included, as you can see on the right. 30% ACER, 50% ACER. These are model-based techniques designed to reduce the dose. And also included in this document is the need for radiation protection, including bismuth shields over the eyes or thyroid, as may be indicated in a particular study. So how would I reduce dose in this particular protocol? Specifically, I would look at the dose parameters. The highest dose parameters are, of course, going to be your tube voltage and tube current. I would turn on auto MA. The tube voltage and tube current, you have to start at some point in your practice, start where you are and dose adjust down very slightly over serial scans and get an idea in your practice as to whether or not you're able to achieve a lower dose without sacrificing diagnostic accuracy significantly. As I mentioned, in our practice, we use model-based reconstruction very frequently. If you have that at your disposal, you can significantly reduce dose as well. On the GE platform, this is called ACER. So some examples of protocols that we have now, we've gone from a simple head protocol and a simple spine protocol to more individualized, tailored protocols. We can have head with and without contrast. Of course, that's a standard dose. A low dose head in cases with suspected fracture, craniosynostosis, in which the evaluation of the brain parenchyma may not be as important. We also evaluate the cervical, thoracic, and heart and lumbar spine, either with or without hardware, 2 separate protocols, and the protocoling physician needs to specify the exact levels which are covered. If a surgeon is interested, for example, only in evaluating the lumbar spine fusion hardware for a lower lumbar spine fusion, say at L4-5, it may be possible simply to scan from L2-3 through L5-1 to evaluate the hardware itself and for the adjacent levels. As I mentioned, we have a CTA-only protocol for patients with known aneurysms for follow-up. With CT stroke protocols, we use perfusion only in those patients who are eligible for TPA or fibrinolytic therapy. Otherwise, the CT perfusion just adds too much dose. We use a standard head and neck protocol that may be dose adjusted based on the size of the neck. And if we're studying bones, either the temporal bones, the sinuses, or the facial bones in cases of trauma, for example, we'll use a lower dose protocol targeted to those structures just to evaluate for fractures. But the bottom line is that the scan parameters are defined for each protocol, for each scanner, based on the vendor and the number of detectors for consistency across the different sites that we have at UCSF. So as a final note, once you've developed protocols and standardized them, it's important to do periodic case review for quality assurance purposes. What we do in our practice is to take a series of cases after adjusting dose parameters. We will review them over a series of months over different patient indications and size. And review them side by side to see how well we're doing in terms of diagnostic accuracy and in terms of subjective image quality. Our group will decide as a group together whether or not the dose parameters need to be adjusted further down or whether or not they need to be adjusted further up. In every case, there's a balance. Dose adjustment is a very complicated issue in CT, as you're well aware. Unfortunately, the vendors are not able to supply a standard protocol, and it really requires your input. So in summary, I think you can make a big difference if you make an effort to get involved. Please don't be passive. Protocols are made, they're not born. Protocols require individual tailoring based on the indication, standardization across sites, standardization across indications, and agreement between the radiologists and technologists in your group to reduce overall dose to patients. One of the things that can really help, and the theme that I hope has come across in this talk, is if you develop an action plan, retrospectively looking at CT data that you've already acquired, ongoing quality review of studies and assessment of individual patients based on their indication, and prospectively planning a strategic approach to dose reduction can significantly benefit the care of your patients.